My name is Cohen Zhong, and today I will present my work on characteristic parameters for DFUs healing. The talk is organized into two main parts. First, I'll give some background, what DFUs are, why they happen, and why the current way we manage them has some serious limitations. Then, I will walk through the characteristic parameters, the specific signals we can monitor to evaluate healing, and I will wrap up with a brief conclusion. Let's start with the background. So, what exactly is a diabetes food ulcer? Simply put, it's an open-wound ulcer that develops on the foot of a person with diabetes. And it's not just bad luck, it's the result of three underlying problems that diabetes causes in the body. The first is neuropathy, or nerve damage. When nerves in the feet stop working properly, patients lose sensation. That means small injuries, a blister, a cut, a pressure sore go completely unnoticed. The wound gets worse before anyone even realizes it's there. The second is poor circulation. Diabetes damages blood vessels, so tissues in the foot don't get enough oxygen, and oxygen is essential for healing. Without it, even a minor wound can stall and become chronic. The third is hypoglycemia, high blood sugar. Elevated glucose creates a hostile environment in the wound itself, disrupting the normal healing process at a cellular level. So you have a wound that isn't well, isn't healing, and is surrounded by an environment that makes recovery even harder. Now, you might wonder, how common is this? Really? The numbers are striking. Between 19 and 34% of all diabetes patients will develop a diabetes foot ulcer at some point in their life. That's roughly 1 in 4 people with diabetes. Of those, 61% of DFUs become infected, and 50% ultimately require amputation. In fact, DFUs account for up to 70% of all non-traumatic lower limb amputation worldwide. And perhaps most alarming, patients with DFUs face a 50 to 68% increased risk of mortality within 5 years. Those are rare edge cases. This is a massive global health burden, and it's one that we currently don't monitor very well. Which brings me to the motivation behind this project. How do doctors currently assess DFU? Mostly through a visual inspection. A clinician looks at the wound and makes a judgment call, but this is subjective and highly dependent on the individual doctor's experience. There's also the issue of dressing removal. Every time a bandage is taken off to check the wound, it can cause pain, disturb the tissue healing, and increase the risk of infection. Another approach is laboratory testing, taking samples and sending them to a lab. This is more accurate, but it's slow, intermittent, and definitely not suitable for continuous monitoring at home. So the question becomes, can we do better? Can we track what's happening inside the wound continuously, non-invasively, and in real time? That's exactly what wearable sensors aim to do. A smart wound dressing equipped with the right sensor could measure chemical and physical signals directly from the wound, and even transmit that data wirelessly to a healthcare provider for remote monitoring and early warning. So, what are these signals and what do we actually measure? That's what the second part of this talk is about. We can group the parameters into two categories. Physical parameters, things like temperature and pressure. Chemical parameters, things like pH value, uric acid, and glucose. Each of these tells us something different about the state of the wound. Let me go through them one by one. Let's start with pH, the measure of acidity or alkalinity. Healthy skin has a slightly acidic pH, around 5, but in a DFU, the wound environment turns alkaline, typically in a range of 7.5 to 8.5. What researchers have found is that as a wound heals, pH drops, moving back toward a more acidic, healthier state. In one 6-week study, pH dropped from 7.8 to 6.93 in healing ones. But in non-healing ones, pH starts high and rises further. There's also a clear link between pH and severity. Mild ulcers have an average pH of about 6.8, moderate one around 7.8, and severe ulcers reach as high as 8.7. A tentative threshold around 7.6 to 7.8 might have distinguished healing from non-healing. Though still being studied, pH is a real-time chemical window into wound status. Pressure is a parameter that matters in two different ways. The first is plantar pressure, the pressure on the sole of the foot while walking or standing. In the metatarsal region, there's a well-established link between high plantar pressure and ulcer formation. Basically, repeated mechanical stress in the foot that can feel pain leads to tissue breakdown. The second is how pressure is used in clinical severity grading. There's a widely used system called WIFI, which stands for wound ischemia and foot infection. The ischemia component is evaluated through pressure measurements like ankle bristle index and toe pressure in millimeters of mercury. These tell you how well blood is flowing to the foot, which, as we discussed, is critical for healing. So pressure monitoring has both a preventive and diagnostic role. Now, for a parameter you might not immediately associate with the wound healing, uric acid. It turns out that uric acid levels in the blood are closely tied to DFU outcomes, but in a nonlinear way. Very high uric acid, about 420 micromoles per liter, doesn't seem to have a significant effect, but very low uric acid, below 180 micromoles per liter, is associated with 4 times higher risk of severe infection. The sweet spot appears to be a moderate range of 180 to 420 micromoles per liter, which correlates with better outcomes. This suggests that uric acid may play a protective role in a wound environment, possibly as an antioxidant, and that monitoring it could help flag patients at an elevated infection risk. Finally, glucose, which is perhaps the most intuitive parameter given that this is a diabetes complication. High blood sugar is consistently associated with worse DFU outcomes. In one study, 57% of patients had very high glucose levels above 220 milligrams per deciliter. Among those, over 52% had severe ulcers. Only about 33% improved and nearly 50% required amputation. But what's particularly interesting is the role of glucose variability. Not just how high your glucose is, but how much it fluctuates. Patients with high glucose variability had roughly 3 times the risk of healing failure. This means stable glucose control, not just low glucose on average, is what really matters for wound healing. So, to bring everything together, DFU healing can be meaningfully evaluated through 5 key parameters: pH, temperature, pressure, uric acid, and glucose. Each one captures a different dimension of what's happening in and around the wound. The exciting possibility is that these signals can all in principle be integrated into a wearable sensing platform, enabling continuous non-invasive wound monitoring without repeated dressing changes or lab visits. This could shift DFU management from reactive, treating complications after they rise, to proactive, catching the deteriorations early and guiding better clinical decisions. Thank you for your attention.